Yeah. Good evening. I'm Bruce Arroll. I'm the Director of the Goodfellow Unit and welcome you to this webinar on managing acute gout and the prevention of gout. Before I start, I just want to talk to you just a little bit about some of the Goodfellow products. We've got the gems, which I suspect most of you will be on the mail base for. The latest one's about hypertension, urgency, blood pressure 180 on 110. If they're asymptomatic, there's no need to refer people to hospital. Okay, so that's the gems. Then we have the podcasts. If you want to find out how to sign up to the podcast, go to our website. You can look at them on the web. You don't need any special technology. Just click on the links. Or if you want to get them in your car when you're driving around and stuck in traffic jams, you can put them on your phone and play them through the car radio. We have this is our general website, so we have the online catalogue with lots of talks and quizzes there, and the recommended health websites down there. So there's a whole bunch of free websites which you may wish to have a look at. And then we have our previous webinars. So we had one about a month ago on common infections made easy. We've had nutrition made easy, TIA and stroke management, primary care with Anaranta, and red rash made easy. So we're making everything easy. That's Paul Jarrett, who's dermatologist at Counties Manukau. So you may be interested to know what resources there are for gout. We have a website called gouthappyfeet.com, which you get through the Goodfellow unit. It has patient handouts, and I'll show them to you in a moment, in English, Samoan, and Tongan, and also the how to treat acute gout and start prevention in 7 minutes. And then there's the Auckland Regional Pathways, which is down there. So it's aucklandregion.healthpathways.org, and that will give you the pathway on how to treat gout. But this is the Gout Happy Feet site, and these are the 3 handouts in Samoan and English and Tongan. And down here we have Stop Gout information. That's probably the best one, but that's written in English, not translated into other languages. And there's some other patient information ones in Tongan and Samoan. So my pick would be Stop Gout, gout information if you've got an English speaker, or the Pharmac one in Samoan or in Tongan. And this is the health professional section. So this is the treating and preventing gout in 7 minutes for diabetics, and treating and preventing gout in 7 minutes for non-diabetics. And there's just some health literacy information which you may find interesting, and a little bit about some other medications for buxostat and benzbromarone, which I will mention a little bit later on. If you want to get access to the gems or to our mail base, I presume most of you are signed up to it, you just need to go to goodfellowunit.org and join, and you will get access to all the goodies. There's no charge for them, so it's all free. So the aim tonight is to talk about how to diagnose gout, how to treat an acute attack, and how to initiate prophylaxis. If you have questions, email them in and we'll stop and we'll take questions from time to time. So we'll just carry on now. So this is, I work in Manurewa in South Auckland, so this is sort of the picture of gout that I see. A Maori or Pacific man coming in limping. There's a special gout limp. It's a pretty painful condition, but these chaps can usually put weight on it. It doesn't look like a sprained ankle as they walk in. But what I like about this picture is it shows gout from the outside, but then has this X-ray view on the inside, because the patients just see this on the outside. They take a bit of anti-inflammatory, it gets better, or they take nothing and it gets better. But they're not aware that this joint damage, so permanent joint damage can be and often is going on underneath the situation. And it's this situation we're trying to prevent by starting preventive medication. Okay, so this was a 40-year-old Tongan man who limped into my office on a Saturday morning. He had no history of injury. He felt well. He'd ate some mussels the night before, does not drink alcohol, and in the notes he'd had 2 recorded gout attacks, and he'd been given Diclofenac on each occasion. So he hadn't been started on prophylactic medication, and he was smoking 1 to 10 cigarettes a day. So he had pain and redness in his right MTP joint, and his vital signs were normal. Now this is quite important because I was involved in a gout study, and we had a man whose temperature was 37.1, and he wasn't allowed in the study because his temperature was over 37, and he turned out to actually have a septic arthritis. So I think if you've got any doubt about people's vital signs, then they should be referred acutely to a hospital in case they have septic arthritis. However, it's pretty rare, and in somebody with a repeat of a previous thing, it's most likely to be gout. He had no other painful joints, and his blood pressure was 180 on 120, and that was probably due to the pain. He was overweight. His BMI was 45. So I diagnosed acute gout based on the location. The first MTP is very diagnostic of gout. The rapid onset had to come on within 24 hours. He wasn't septic. He'd had previous episodes, and he was of Polynesian descent. So Maori and Pacific people have a gene which causes gout, and I'd say it's about present in half the families. So I see some men who have nobody in their family with gout, and I see other men where everybody's got gout in the family. It's much more common in men than in women, but it is a condition of aging, so it gets much worse as people get older. By the time you're 60 as a Maori or Pacific Island man, there's a 25% chance you'll be on allopurinol. That's not counting those who aren't and perhaps could be on allopurinol. Now the issue is, should we be doing needle aspiration in accessible joints? And the answer to that is no, unless you're really good at it. And even Peter Gow from Counties Manukau doesn't put needles in joints anymore. But I'll talk about other ways of making a diagnosis if you're uncertain. But clearly a history is enough to normally do it. And this is some information from a study done in the United States. So what helps with the diagnosis is a uric acid greater than 0.35 millimole per litre. That should not be deciliter. And the first MTP joint, being male, previous symptoms in the same joint, not joining, so, and either a high blood pressure measure or greater than 1 CVD conditions. Now clearly in this study there were no Maori Pacific, but that would add. What's interesting about this is the uric acid. If somebody other than outside of the acute attack has a serum uric acid less than 0.36, that would help rule out gout. Not absolutely, but I'd have to say it's very unusual to see many people, particularly Maori or Pacific men, without a uric acid below 0.35. Differential diagnosis would be septic arthritis or pseudo-gout, and people have pseudo-gout and gout at the same time. So often you have previous blood tests for these people, and in this man's case we had a serum creatinine of 102, his eGFR was 70 ml per minute per 1.73 meters squared. His urate on a previous occasion had been 0.58. One thing you need to be careful about checking a serum urate in an acute attack. If it's normal, that doesn't rule out gout, because some people with acute gout can have normal uric acids, the theory being that uric acid comes out of their blood and into their joints. I have to say that's not been my experience, but in people like Peter Gow say it is something to watch out for. It's reasonable to do a serum urate at the time if you're going to be doing blood tests, but just keep that in mind there. So how to treat an acute attack? So there's essentially 3 different treatments you can do. Oral NSAIDs, Nurofen, or ibuprofen, or Voltaren. Oral prednisone, you need to give at least 30 milligrams. In New Zealand, 40 milligrams is the more convenient one. Or oral colchicine. And colchicine is interesting because maximum dose should be 500 micrograms up to 4 times a day. But actually, for prevention, twice a day is better than 3 times a day with fewer side effects. So, so it's just something. So go low and slow on the colchicine. And that needs to be given for up to 2 weeks or until the pain's gone. So this is just treating the acute attack. And here's just a summary of what you can do for gout. So this is the treatment of the acute flare. So non-steroidals, colchicine, prednisone, and if you're really good, intra-articular corticosteroids. So if you had somebody you thought had gout in their knee, you could put a needle in, take some fluid out, and then pop some intra-articular steroids in. But you may feel happier just giving oral steroids. So then there's the issue of giving prophylaxis against acute flares when you start these medicines over here, the urate lowering therapy. And there are 2 xanthine oxidase inhibitors. There's allopurinol, which we're all familiar with, and the new one called febuxostat, which has 1 or 2 advantages over allopurinol, but has a pharmac restriction on it at the moment. And then there's uric agents, probenecid, which isn't particularly wonderful, and another one called benzbromarone. That's probably the sort of thing you should leave for rheumatologists, but all the rest we can consider using ourselves. Now, when you're starting these urate lowering therapies, one of the problems with starting urate lowering therapy is you trigger off gout attacks, and it's a good reason not to start off at a top dose. So with allopurinol, you should be starting at either 50 or 100 milligrams a day, alternative days in people with poor renal function. And when you start urate lowering therapy, you will start getting prophylaxis. And so to prevent that, you have to give these medications with these medications over here, prophylaxis. So non-steroidals perhaps, although that means giving them for 3 months or so, colchicine, and in some cases low-dose prednisone if people have poor renal function. You don't want to give an NSAID and they don't want to take colchicine. Sometimes all you've got is to give low-dose prednisone. So that brings its own problems, of course, having to get people off. But you need to give prophylaxis for about 3 months, because in that period people will start getting flares, and that can put people off getting. But if you warn people, then I think there's no problem with that. Feel free to start putting in questions if you have questions. So management of gout. Prevention is suggested if people have had more than 2 attacks in the previous year. And we're seeing young men in their 20s, usually Pacific or Maori men, and understandably, if you're 22 years of age, you're not too excited about taking a pill every day for the rest of your life. And they often think that means they have to stop drinking alcohol. Young men like alcohol. But I think one of the sales points is, well, if you take the preventer, the allopurinol or febuxostat, you can drink alcohol and you can eat seafood. Obviously, we don't want to be encouraging to drink alcohol, but we, on the other hand, want to encourage them to take preventive care to avoid that long-term damage. So by taking preventive medication, you decrease the number and severity of acute attacks. In fact, if you get the uric acid below 0.36, or certainly below 0.3, they should never have another attack again. So if you can get them down low enough, then below 0.3, and they will probably never have another attack. You're reducing damage to joints, damage to kidneys. You may be reducing their cardiovascular risk. There is some evidence that allopurinol may reduce cardiovascular risk, but that's still, the jury's still a bit out on that. And you have to check for comorbidities as well, because particularly men with gout usually have other things like high blood pressure and cholesterol problems. So how to start prevention therapy? After the acute attack, you can start allopurinol at a low dose. We did a trial where we gave people allopurinol during an acute attack, and it doesn't seem to make things any worse, but there's still controversy. So I think the easiest thing is just to leave the allopurinol until 2 weeks and get the acute attack controlled. The suggestion is to take it for at least 1 year, if not preferably for life. Treat to the target of less than 0.36, and colchicine prophylaxis. There's no easy answer to this. 3 months isn't probably as good as 6 months, but patients get sick of the medication load, so that they prefer to not be taking quite so many medications. So marketing the therapy, I think this requires our marketing skills, which we have lots of in primary care. So I say to patients, well, it's okay to drink some alcohol, and you can eat seafood, and so long as you're taking the medication. But I think we actually have to work out what's important to people, and then link that up. So if going to family gatherings and not missing time off work is important, then I need to say, well, that's, on the one hand, that's important. On the other hand, the controlling your gout is going to help you reach those values, because patients don't necessarily have the same values as we do. And I think if we can connect what they think is important to controlling their gout, then we can help and make that connection. But of course, there's many, particularly younger men, aren't that interested, and it's pretty easy when they're over the age of 40, but when they're under the age of 40, I'm sure you've all had that experience of having trouble. Just some other things, harms and other issues. Allopurinol does not harm the kidneys. The reason why you reduce the dose when the kidneys are not functioning well is so that you don't get a high serum dose of it quickly, because that can trigger off a gout attack. And also, the other reason not to start off with high doses, if you start off with 300 milligrams, you'll almost certainly trigger off a gout attack, another one, which makes patients lose faith in the medication. And it's well known in the Samoan community that allopurinol is considered to cause gout, and that's the result of high doses. But the other thing is the high dose is associated with the hypersensitivity reaction. Now that's very rare. That's about 1 in 10,000. That's when people lose all their skin, and about 1 in 3 of those people die. So about 1 in 30,000 people will die from taking allopurinol. So it's worth starting low. And if you start low and go slow, then that doesn't happen. Now the other thing is that the normal range for the lab is 0.2 to 0.42, and I've been in contact with Arlo Upton from Lab Test to see if they can change that to 0.36 as the target, because a normal range of 0.2 to 0.42 doesn't make any sense. It's probably just a 95% confidence interval, and I'm pretty sure that doesn't apply to Maori and Pacific men, because pretty well everyone I see has a higher uric acid than 0.42. But when you start treatment, then you want to hit a target of 0.36. So you may notice a change in the lab forms fairly soon, because that confuses people. So the target is not 0.42, the target is 0.36. And if you want to reduce tophi, then you have to get down to 0.3. So take-home message number 1 is start low and prevent flares. And the serum urate less than 0.36. So we now hammer this into medical students. Does this sound okay? Mm-hmm. Okay, so comorbidity checklist for gout. So there's the metabolic issues, obesity, dietary factors and diabetes. There's issues of excessive alcohol intake. And there are certain cardiovascular medications and just having a high BP are associated with gout. And you need to be careful with the diuretics. If you want a urate lowering drug, then the angiotensin II receptor blocker losartan actually lowers uric acid. Sometimes with patients, when you have to add a diuretic to get their blood pressure under control, I've had the situation where I've had to go and get their gout under control because every time I give them a diuretic it triggers off their gout attacks. So it is one of the downsides of using diuretics, which is unfortunate because diuretics are the single most best low blood pressure lowering drug if you look at the evidence. But you need to be a little bit careful with people with gout. The other situation is chronic kidney disease. Of course, that's going to make gout more of a problem. And of course, as people get older, their kidney function gets worse. By the time you're 70, essentially you're down to one kidney, and that means the uric acid gets higher. So how could this man be treated? So this will, he could have been given something like Diclofenac, 50 milligrams 3 times a day for 2 weeks, and then after that started on 100 milligram daily for a month, and then 200 milligrams daily, titrated up to about 300, but it's titrated against blood tests. Now in the average male this age, you at least need 200 milligrams, so it may not be worth doing any blood testing until you get to the 200 milligrams. The downside with allopurinol is that means 2 tablets. So it's 1 tablet for a month and 2 tablets for a month. If you can get them to 300, then you can get them back onto that. But the key thing is the blood tests, and some of the community laboratories are now getting finger prick uric acid tests, which are going to make this much easier to manage. In fact, we're trying to work a system in our clinic whereby patients can bypass us and just get their prescription picked up at the pharmacy, which is downstairs from us, and get a uric acid. Because there's all sorts of barriers for these guys. They're reluctant to take time off work. They're not particularly fluent or experienced in coming in for preventive care, and we're trying to make it as easy as possible and actually take our practice out as a barrier, so we can call them by phone, we can post out prescriptions, and they can get their blood tests, finger pricks at the lab. Now that's not all pharmacies, but I think that's coming. That'll be coming your way, certainly if you live and work in Auckland. So the other thing this person would need would be colchicine, 500 micrograms BD to prevent flares. Colchicine does cause diarrhea, but in this dose, 200 milligrams doesn't cause diarrhea very often. You can go down to 1 tablet a day. Now the alternative is to go to the gouthappyfeet.com website, and you can go to the How to Treat and Prevent Gout in 7 Minutes. And this is the gout starter pack for those without diabetes. So there's different levels of EGFR over here. So EGFR greater than 60 or 30 to 60. And if you look on the Gout Happy Feet, there's a less than 30 there. Blister Pack 1 is 40 prednisone for 4 days. Blister Pack 2, allopurinol and colchicine. Blister Pack 3, allopurinol and colchicine. Blister Pack 4, allopurinol and colchicine. So this just gets patients, they don't have to think about their pills, they just pop the plastic piece and away they go. So you need to have a relationship with the pharmacy. So our local pharmacy has these option 1, option 2, option 3, and so we'll write Gout Starter Pack option 1, and they will start them off, and away they go. So it really makes it easy for patients, and they really appreciate it. Some precautions with colchicine. Those of you who went to medical school when I was there, we were told to give it every 2 hours until the patient got diarrhea. Well, the risk with that was some people got killed with liver failure. So so you have to be careful. So these days we would say never go above 3 per day, maximum of 3 per day for preventing, but I would suggest 2 per day, even going down to 1 per day. There are a few drug interactions you have to watch out for, and it's contraindicated in pregnancy. But other than that, if you use it judiciously, it's probably safer than giving NSAIDs, and you don't have the problems of prednisone. But you may have to go to those other options. Now, this is just a lovely quote. This is from our study, and I'll just let you read it because it just shows you how grateful people can be for having their gout treated and how useful the blister pack is. So I'll just give you a few minutes to read that. So you can see this man was very pleased. He found it easy. He'd had a long history of having gout affecting his life and his work and his church. So that's the sort of gratitude you can get from people for getting their gout under control. Primary prevention of CVD, this was his cholesterol pattern, so a bit low on HDL. He had pre-diabetes, HbA1c of 45. His blood pressure, when seen later, was 170 on 105. His 5-year CVD risk was 15%, so certainly time to start him on blood pressure lowering medication, and so losartan would be a good one from him. Losartan's on as a generic now, and actually it's quite cheap, so I'm even thinking of starting ARBs rather than ACEs because you get around the cough problem. There's no cough problem with losartan. So, and I find losartan a very good blood pressure lowering drug, particularly when it's added to hydrochlorothiazide. Although, as I said before, you want to be a bit careful with giving diuretics. The famous risk tables, Rod Jackson will be pleased that I've shown it. That's just to show that we've assessed his CVD risk at 15%. This picture is now etched in the mind of every Auckland medical student. They come out of it with their retinas tattooed with the New Zealand risk tables. Okay, so lifestyle versus drugs. So diet and exercise is good for CVD risk, but I'm part of a group at Counties Manukau DHB called the Maori Gout Action Group, and we have pretty well given up on using diet to control your gout. You can, in some people, control recurrent gout by going onto a very well-controlled puring, low puring diet. Okay, but it gets very difficult, and as people get older, their kidney function starts to dive, and they get problems with gout. So really, unless somebody's really pushing for it and is super keen, I would suggest they go for the medication option. Now, the other issue is that a high uric acid in somebody who's never had gout is not an indication for treatment. Okay, so we're just getting some questions here. So. Okay, so we've got a question here about how much prednisone. Outside of an acute attack, probably 10 milligrams a day is recommended. Clearly, you're going to be suppressing the adrenals, so when you get to the other end of that after 3 months or so, then you're going to have to withdraw that. If you're going to use prednisone for treating a flare, you might have to use 20 milligrams, but that's when you've actually got inflammation. When you've got just preventing a flare, then 10 milligrams is probably enough for that. So we've just got another question here.
What prophylaxis would be the choice for someone with diabetes and renal insufficiency?
So choice for somebody with diabetes and renal insufficiency. Well, clearly you want to be a bit careful with NSAIDs. That would be probably colchicine would be the treatment of choice there. If you have to go to to prednisone and you had a diabetic, it would depend how badly controlled their diabetes was. And I guess if the worst came to the worst, you might have to balance insulin versus prednisone to get somebody started. But I haven't come across a situation like that. I'd have to say it's pretty rare.
What about hyper?
Yeah, so hyperuricemia alone is not an indication for gout. So we just had a question on that. So you've got to actually have clinical gout before you'd warrant starting allopurinol. Now in future that may change. But on current knowledge, it's not recommended that you'd start allopurinol just for hyperuricemia.
What frequency do we?
Okay, so titrating allopurinol, probably at least have every 2 weeks. On the 7-day treatment and prevention, it recommends a month. It doesn't matter. I think 2 weeks would be minimum. A month would be absolutely fine. Again, these rules are plucked out of the air and might be something you want to negotiate with the patient, basically. Remember, that's what we do most of the time.
If someone's run out, after what length of time off meds necessary to retitrate?
Okay, if somebody's off allopurinol, then when do you need prophylaxis to up-titrate? I don't know the answer to that. I guess it's just one of those things you just might have. If they've missed a few days, then you might want to just get them back on where they were. If they've missed a few weeks, you might have to go back through the prophylaxis thing, painful though that may be. But again, I think that's something for a negotiation with the patient.
Can children get gout?
I'm going to say no. We have got a man in our clinic who has a genetic form of gout. In fact, he's the only one we haven't been able to get. I think he's been on 700 milligrams of allopurinol. He had it from a very young age, I think his teenage years. I guess you never say never, and I'm sure the rheumatologists probably see the odd person, but it would not be my first differential in a child if they came in with a sore joint.
When do you start long-term treatment?
You start long-term treatment after 2 attacks in 1 year. That's an international criteria for starting allopurinol.
Would a urate level of over 0.6?
No matter how high uric acid is, if they've never had gout, they should not be given allopurinol. The question was greater than 0.6. If it's greater than, no matter what it is, and it never goes much more than about 0.7, 0.8, but a high level on its own is not an indication. For some reason, those people don't develop gout. So the uric acid is just, it's only of use to know the uric acid so you can get it down with an appropriate dose, the actual level of it, or if it was very low in the presence of a recurrent gout, you might want to think. But I'll talk about other ways of diagnosing gout because there's some new gear that helps that. So,
what's the relationship between gout attacks and kidney damage?
I don't think any. That's not. So the question is, what's the relationship between gout attacks and kidney damage? People who get kidney damage seem to have a lot more gout attacks. I don't know if that's been quantified, but that's certainly one of the reasons for wanting to get uric acids down, particularly in the presence of gout. But my understanding is it's an area that isn't that well mapped, not as well mapped as the treatment, although actually the randomized trials on treatment have been very recent.
Do you have to add?
So if you can try and keep the questions short, we've got a very small window on the computer to be able to read them, and they're coming in so quickly we can't. I mean, I guess it's a debate. If somebody's getting an attack once a year, whether you'd want to go on to allopurinol, that becomes a bit more of a negotiation with the patient, I think. Depends how much they're bothered by it. We've found a whole lot of people who aren't getting attacks that often and don't want to go on to allopurinol. So it's a balance, isn't it? Okay, so we're going to get on to when the eGFR is less than 30 because the guidelines all suggest discussing that with a rheumatologist, although those people, of course, are going to have lots of problems with gout because they're going to have people with renal problems have problems with gout. So the take-home message is we need to deal with the acute attack. Consider the use of blister packs. Now that does require you to communicate with your pharmacist. You can take those files off the gouthappyfeet.com, get them to your pharmacist, and they will make up the packs as you need them. Start low, go slow, flare prophylaxis with colchicine, and target uric acid at below 0.36 and lower if you've got tophi. Okay, we've got some more questions here. Yeah, so the question here is reducing uric acid from 0.8 is not protective of the kidneys. Not as far as we know so far. I'd have to say there's probably an absence of evidence on that rather than evidence of absence. Surprisingly, there's surprisingly little research on some of these things with gout. Do prednisone and colchicine have an additive effect? I don't know the answer to that question. The prednisone in my situation would be to give it to quell the acute attack. Some people need colchicine and NSAIDs as well to get an acute attack under control. But once you've got over the first 2 weeks of prednisone, then colchicine alone should be enough. And in the trial I was involved with, that really wasn't a problem after the acute attack. Okay, so our next case is a 77-year-old Maori woman. She presents with frequent episodes of ankle pain, and interestingly she had a lump on her first MTP, and I thought, aha, she's got a tophus. So we got it x-rayed and it turned out to be a bunion, and she was getting leg cramps and allopurinol and wasn't very happy. So at the time the company gave me some samples of febuxostat, and I gave her the first dose, which was 80 milligrams, which took her uric acid down to 0.22. So one of the advantages of febuxostat is on the first dose you seem to get quite good uric acid lowering. You still have the risk of flares, but and febuxostat's okay in mild to moderate renal failure, but again, it's like you don't use it unless the eGFR is greater than 30. Now, what was interesting with this lady was that there was so much doubt about whether she had gout or not that we referred her to the rheumatologist, and they did a thing called a dual emission CT scan, which made the diagnosis of gout. And I'll just show you what that looks like. So on a dual emission CT scan, you get these little green bits there, and that tells you you've got gout. Now, in some of these people, normal X-ray doesn't show they've got gout. You can sort of see here the joints aren't being that badly affected, and so it may not show on X-ray. So this is the and there's one of these scanners at Middlemore and at Auckland. I don't know whether there are some outside of Auckland. I presume there are, but in the New Zealand Health Service they may be able to get you to Auckland to get these things. So, but anyway, in this lady it was very good because it meant then we could go all guns blazing to get her uric acid under control because we knew she had gout. She had a creatinine of 115, eGFR of 0.4, uric acid was 0.55 initially, and she ended up on allopurinol 200 milligrams, so we got her to push through the cramps, and the uric acid is now 0.3 and she's very happy. So we'll just see what the questions are coming in. No more questions? Okay. So we'll go over to 60-year-old European man, frequent episodes of pain in the MTP joint, which is nice because that makes the whole diagnostic process easier. Uric acid initially 0.48, EGFR 42. He was on a lot of other medication. He was on furosemide. He's on a whole lot of blood pressure medications, and he presents with an acute attack. So, so with him, you can start a blister pack, and in his case, you'd start him on allopurinol 50 milligrams daily for 28 days with colchicine 1 tablet daily, and then the prednisone acutely in a decreasing dose. His uric acid at 1 month was 0.41. He was then up titrated to allopurinol 100 milligrams daily for another month, and colchicine 500 micrograms daily, and his uric acid was 0.33. At that point he didn't need his allopurinol raised. Unfortunately it meant he had to take 2 pills a day, but that was the breaks and he accepted that. But he did want to stop his colchicine, so I said, okay, you know, there is a risk if you stop this. We don't know how long you're supposed to take it, but some people recommend 3, some people recommend 6 months. And he had a big pill load, so he was happy with that. So he's gone off happy, and hopefully he'll have no problems. And I gave him a rescue prednisone 20 milligrams for 7 days. But clearly you might want to see somebody if they're having an acute attack in case they have septic arthritis. So it's just something you have to be careful about. I think it would be hard to live with yourself if you gave somebody prednisone on top of an acute septic arthritis. So patients with EGFR less than 30. So according to the guidelines, you would give 50 milligrams alternate days for 28 days, check the uric acid, and if they're not below 0.36, titrate up to 100 milligrams for another 21 days. And in those people you would give colchicine on alternate days. It's recommended you discuss these patients with rheumatology. I'm not sure what they would do differently because these people, particularly as they get near dialysis or on dialysis, gout's a real problem. The other thing would be to use benzbromarone. Now it's not used very often. It is available in New Zealand and it's quite good for people, I understand, who've got renal failure, but I've had no experience with it, and the rheumatologists are just getting their heads around it now. So we have one question. We'll go to the question.
How did your previous lady get rid of the cramps?
How do they get rid of her leg cramps? Well, I suspect in retrospect they weren't associated with the allopurinol, but of course she thought they were and wouldn't take it. And then she was okay on febuxostat, and then I lost track of her because she's actually the patient of one of my colleagues. And then she got the dual emission CT, which showed the gout, and so I think then my colleague was able to go back and push the allopurinol. I think there was a period there where febuxostat may have been hard to get. I can't quite remember, so there was a bit of a gap in my knowledge there. But I suspect that there was no association with the allopurinol. They were just coincidental things. Of course, hard to establish cause and effect. Okay, optimal time to measure uric acid after an acute attack. I don't think anybody knows, but probably 2 weeks is too soon. Probably 3 or 4 weeks would be reasonable, because remember, after 2 weeks the inflammation is just settling down. Having said that, if you get one and the uric acid's above 0.36, you know, if it's 0.5, well then there's no problem. The only problem comes if you got one back and it was 0.34. Then you've got a problem. Then you'd want to repeat it. Then I probably would wait a month. But I have to say I've done lots of uric acids in patients with acute gout and haven't had any problems with that. So.
Why is gout so often in the first MTP?
Why is gout so often in the first MTP? I don't think anybody knows. The thought is that it occurs in the foot because it's the furthest joint from or it's getting a long way from the heart, and it gets cold, and it's a precipitation caused by the cool extremity. That's the best answer that anybody's come up with for me. And I guess the MTP joint is big enough to have a problem. But then gout can occur in any joint, but it's usually in a single joint. It's not bilateral, and it's usually not in 2 joints. It'd be very rare to have it in 2 joints. Occasionally occurs in the back, interestingly enough. Well, I don't know how you'd ever diagnose that, but I've never come across that sort of situation.
The scans you spoke of earlier are available in the main centres. What's happening for people in rural areas?
Not sure what's happened. The question about the dual emission CT being available in rural areas, I would suspect if it was a burning issue with the patient, the DHBs would arrange to get the patient to counties or Auckland. They're the 2 places I know with the CT scanners. But I think they will just become standard kit and DHBs in time. There was only 1 available in Auckland until recently. Now there's 2. But it's hardly needed. It's more a research tool, really. It's hardly needed. That's the only patient I've ever found it useful in, when there was some doubt and the patient wasn't happy with the medication, and the clinical picture being in the ankle wasn't that clear. She was having gout. If someone's getting pain in the first MTP joint, I don't think that you'd need to do that. You just get the uric acid down and just assume it was gout, so long as everything else added up.
How significant is diet in initiating an attack?
The role of diet in initiating an attack. I've met patients who find it triggered off by tomatoes. Clearly seafood, it's got puring in it. Foods with puring in it can trigger off gout. Beer seems to trigger off something to do with the yeast, seems to trigger off gout. So diet certainly can trigger off gout. So alcohol, seafood. So if people have a big night with alcohol and seafood, then they notice the next day that the gout's coming on. But don't assume people are drinkers because they get gout, because many of the Pacific people don't drink alcohol at all.
One of your colleagues have a hypothesis about first MTP.
Good thought there. The first MTP gets a lot of micro-trauma. I'm sure that's probably, and we know that trauma sometimes does trigger off gout. Of course, it's always a bit tricky. I had a patient the other day who thought he'd sprained his ankle, but it turns out that he probably had gout. So he came in with a sore ankle, having said he injured it at rugby, but I think, in fact, the problem was gout all the way through. So,
would you check monthly urate and renal function? For how long and how frequently?
Should we check the urate and renal function? I think once somebody, it's now recommended just doing it once a year once you're down to target. So there's no particular reason for once a year. Once every 2 years will be just as fine. Depends how much taxpayers' money you want to spend, but it's recommended once a year there afterwards to check if people are still taking their allopurinol, because the moment they stop it, their uric acid will go roaring up. It's like the statins. You can tell the moment someone stopped their statin.
Some people are on colchicine long-term for gout. Prophylaxis, is this advisable?
Long-term prophylaxis with colchicine, if they're not on allopurinol and that's the only way you can control their gout, that's not an unreasonable thing to do. But if they're on allopurinol or febuxostat or anything else, there's no need for colchicine long-term. I remember a patient once who kept taking it because it was good for his constipation, the diarrhea creating things. He quite liked taking his colchicine.
Diclofenac long-acting or short-acting?
Diclofenac long-acting or short-acting, this is completely anecdotal, but I think the short-acting stuff is better. People need a fairly big hit. This is a very, very inflamed joint. And in fact, one of the diagnostic things is they shouldn't be able to have the bed covers on their foot. It should be so sore they can't stand a sheet on their foot. If they can stand sheets on their feet or bedclothes, they probably don't have gout. So it's a rip-roaring, I mean, essentially it's uric acid crystals, literally glass in the joint, and I think they need a short-acting big doses of non-steroids. In the old days it used to be indomethacin 50 milligrams 4 times a day, so it wouldn't hurt to go even higher. Some people use intramuscular Kenalog. You've got a question about that? Injectable diclofenac over oral diclofenac. I don't think, again, I think I would just use your own judgment on that. Obviously, the intramuscular would be pretty good in those situations. Some people, I've met some South African doctors who use IM 40 milligrams of triamcinolone intramuscular steroid, and there are trials showing that that is an effective treatment. It may take a day or two to kick in, but I think everything takes a day or two to kick in. These are pretty rip-roaring inflammatory arthritis situation.
Is the finger prick on the schedule?
Finger prick's not on the schedule. It's part of a program at the moment, but you can see what we're doing in our clinic. We've got all these men in jobs that they don't like taking time off, and even going to the lab's a hassle. You know, you go to our local laboratory and you can be waiting 2 hours for a blood test. So I think we'll start to win with gout if we can get the finger pricks. And I think if you're not in one of the Auckland DHBs, I would start pushing for it, particularly if you've got a lot of gout. If you're in an area with a high Maori or Pacific population, I would start pushing for it.
How accurate is that finger prick test?
Finger prick test is pretty good, actually. With the that's different from there are some kits you can get and do them in your office, sort of like blood glucose. They're a little bit more dubious, but the ones they do at the pharmacy here, I think they're using the Roche machine, and they're pretty good.
Are prawns and shrimp high in purines? Are they considered shellfish?
Prawns and
shrimp.
I think they are high in purines. I would have to look that up. Not considered shellfish according to my assistant here. So I've always thought of them as shellfish. I have a very weak definition of shellfish, I think. Not been a great shellfish eater. Okay, any more questions, folks? Okay, so if we, so take-home message, basically deal with the acute attack, blister packs, start low, go slow, flare prophylaxis, uric acid 0.36, low EGFR, talk with rheumatology. We've got one more question. Okay, question is, if you need to up-titrate somebody later on, I suspect the rule probably should be consider prophylaxis whenever you're up-titrating, because that's the risky moment. I think if somebody had been on long-term, if you're just trying to get the last few, if you're trying to get from 0.8 to 0.35 after a year, you might get away with just without prophylaxis. But I think if you explain to the patient, then they're probably going to be happy to do that. Okay, the finger prick meter is called a Benometer. Sandra from Manyarewa Pharmacy. Thank you, Sandra. So they're one of the pharmacies we're working with. So okay, so the next webinar is in a couple of weeks with Venu Bamidipati. He's going to talk about vascular disease and vascular emergencies. He's a great and keen teacher, and those of you who are on the webinar today will be on the Goodfellow mail base. And we understand there haven't been any problems with sound, because the hidden agenda of doing tonight was to check our sound. So
18-year-old with 3 attacks, should you start allopurinol?
18-year-old with 3 attacks, should you start allopurinol? Well, going by the 2 attacks in 1 year, you probably should. Now, some of these young people will be drinking 3 bottles of Coca-Cola a day, and they're not small bottles, they're big bottles. Fructose-containing drinks elevate uric acid. If they're going to drink soft drink, then the zero drinks, the non-fructose ones are the ones to go with. So yeah, so with a young person, I've seen a man at 35, Samoan man, whose hand was so mangled, but you couldn't even shake his hand. He just had this little claw of a hand, and he just had tophi everywhere. And I think he'd had gout from when he was very young. So Is Diclofenac better than naproxen? Don't think anybody knows. I think just go with your favourite one. If it was going to be Voltaren, for me it would be 50, 75 TDS, or naproxen 500 BD, ibuprofen 200 TDS, 400 TDS. You really want to make sure people have got adequate pain control. I've got very comfortable with prednisone, so my pick now probably would be prednisone, but you are taking a bit of a risk there.
Audio and picture very good.
Oh, good. Thanks, Ross. Audio and picture very good. So we'll just bring you back. So thank you very much for being on the webinar tonight. Hope you enjoyed it. Send in some feedback. That would be good. We've had good feedback about the webinars. Nice way to be educated. You can be sitting at home and having a nice relaxing time. So thank you very much. So from us, over and out.
I think you stopped it.
I haven't done anything here to do that.